Assalamu alaikum. From now, inshallah, we will switch our lectures from the traditional way into a video sharing form. Given this special time, we decided to start our lecture with COVID-19 related kidney disease, whether it's an acute, chronic, or acute and chronic cases, regardless if it's in the center or in the ICU or medical wards. We'll have 3 lectures starting today with Dr. محمد حميدة. He will speak about acute kidney injury with the COVID-19 patients. He will touch base on pathophysiology, diagnosis, dialysis modalities, and the use of other medication and their implements and side effects and dose adjustments regarding kidney function. We will have 2 more lectures and we will share them at that time also. Thank you very much. Please be safe.
Today I will present acute kidney injury associated with COVID-19 disease. In the view of the pandemic of COVID-19, we have an updated questions and answers regarding acute kidney injury. So what is the risk of AKI in patients with COVID-19? The incidence of AKI ranges from 0.5% to 23%. It seems to develop at a median of 15 days of admission. Also, it was developed within 7 days in other study from admission. COVID-19 incidence of AKI in one study, Necker et al. It was published in Kidney International 2020. The incidence of AKI was 0.5 to 23%. It was more common in ICU setting, and especially in ICU, the incidence increased from 8.3 versus 2%. The need for CRRT was 0.8 to 9%. Some urinary abnormalities like proteinuria and hematuria showed around 63% of proteinuria and 26.7% hematuria. The risk of AKI in one study, cohort study, the number of patients was around 1,000. It was 0.5. Another study, the AKI risk was 23%. The need of CRT ranges also from 0.8 to 5%. The other or the associated comorbidities associated with AKI, the most common comorbidities was diabetes, hypertension, CKD, and also cardiovascular disease. The potential injury mechanism was that the COVID-19 virus binds with ACE2 receptors, which is expressed in the kidneys, and there is high expression in podocytes and proximal tubular epithelial cells. What are the causes and characteristics of AKI in these patients? Mostly AKI, most likely cause of AKI was sepsis, AKI, and multi-organ failure, and the most prominent is the cytokine storm syndrome. It showed that respiratory failure from ERDS is the leading cause of mortality, and secondary hemophagocytic lymphohistiocytosis and hyperinflammatory status was associated with fatal hypercytokinemia and multi-organ failure. The cytokine storm syndrome ranges from 3.7 to 4.3 of the sepsis cases, and the cardinal features of the cytokine syndrome was unremitting fever, cytopenias and hyperferritinemia. The pulmonary involvement, including ARDS, occurred in 50% of these patients. This slide showed that how the COVID-19 virus, when attacking the body, it will cause overactivation of the T cell, mostly CD4 T cells, and the most fatal and most prominent cytokines was interleukin 6 and granulocyte colony stimulating factor, and this is the most prominent interleukin 6. That's why interleukin 6 antagonist blocker tocilizumab was used successfully in the treatment of severe COVID-19 patients. Is it possible for SARS COVID-19 virus to be present in urine and CRT effluent? Yes, there are pre-printed reports that COVID-19 has been isolated from urine of the patients in Guangdong and Wuhan hospitals, but the presence of viral RNA has not been established as a direct link to the kidney injury. Regarding CRT effluent, only 1%, 3 of 300 samples showed the virus, and this lowers the likelihood that effluent would be infectious. The virus shedding was most commonly from bronchoalveolar lavage, 93%, followed by sputum 72%, and even feces 29%. What about proteinuria and hematuria? In one study, Ching et al. Published in Kidney International 2020, studied 701 patients at single center. The incidence of proteinuria was 44% and hematuria was 27%, but was unclear whether proteinuria and hematuria were due to AKI or underlying CKD. What is the pathological findings regarding kidney involvement? In 6 patients' autopsies, the light microscopy mostly showed severe acute tubular necrosis with CD68 macrophage infiltration of the tubular interstitial. Also C5b9 deposition on tubules was observed in all 6 cases. Another question, does AKI associated with worse outcomes? From the 2005 SARS experience, the mortality from the current epidemic, the AKI as a cause of death was associated with 4% of the patient in one study, Zhang et al., published in March 2020. Also, another study showed around 23% had AKI. Should we start renal replacement therapy early for these patients? As we know from all trials, AKI trial and Ideal ICU trial, 2016 and 2018, it was reported that no difference in outcomes for early versus late start. Especially in COVID-19, severe pneumonia and ARDS, the volume is an important and frequent reason to initiate renal replacement therapy. Does the modality matter for the treatment of AKI in this setting? As we know, the continuous therapies like continuous veno-venous hemodialysis and continuous veno-veno hemodifiltration, we can use also hybrid therapy like prolonged intermittent renal replacement therapy, SLIT. There was little difference in outcomes. If the CRRT or PIRRT are not available, the intermittent hemodialysis is acceptable. One issue here is consumables for the CRRT. The tubings, dialysate and replacement solution bags may run low if usage is high. The kidney involvement in COVID-19 was associated with potential and different mechanisms, and that's why the rationale for extracorporeal therapies are different. From the different potential mechanisms of kidney damage, the cytokine release syndrome was one of the causes, and this syndrome caused direct cytokine lesion. That's why the suggested treatment strategy was cytokine removal using various approaches like direct hemoperfusion or CRRT with hollow fiber filters with adsorptive properties, and also use of high doses of CRRT with medium cutoff or high cutoff membranes. Another mechanism of kidney damage was organ crosstalk, or like heart kidney direct association. As a virus, severe COVID-19 can cause cardiomyopathy and viral myocarditis, so the mechanism of kidney injury mostly will be cardiorenal syndrome type 1. So at that time the suggested treatment strategy will be LVAD and arteriovenous ECMO. Another cause of the heart affection from COVID-19 is alveolar damage, well associated with renal medullary hypoxia and renal compartment syndrome. So the suggested treatment strategy will be veno-venous ECMO and extracorporeal CO2 removal and CRRT in combination. Another modality will be rhabdomyolysis associated with tubular toxicity. The CRRT is recommended using high cutoff and medium cutoff membrane. Another systemic effects will be present like positive fluid balance and increased the endotoxin levels as a cause of septic AKI. The most important here is continuous ultrafiltration and using CRRT with high cutoff and medium cutoff membrane. What is the role of hemoperfusion? The cytokine removal is mainly carried out using a neutral macroporous sorbent. The hemoperfusion should be used for more than or equal to hours on 3 consecutive days. We should take care of anticoagulation with heparin or citrate during the procedure, along with blood flow more than 120 ml per minute to prevent premature clotting of the circuit. The best quality data is from EUPHRATES trial in 2018. This multi-center trial included 450 patients with septic shock and high circulating endotoxin levels. Polymyxin B hemoperfusion, which does remove endotoxins, was compared to sham hemoperfusion, and there was absolutely no difference in any outcome. Is the risk of filter clotting higher in these patients, and why? Yes, these patients have a very high inflammatory response, termed cytokine storm and hyperinflammation, and the experience is higher filter clotting. How to reduce the filter clotting? We know to increase the blood flow, to use pre-dilution replacement fluid and for hemofiltration, and also dose heparin infusion appropriately. There is some technical consideration we can perform with ECMO and CRRT. As we know, the hypoxia is a major factor, and some patients may end up on ECMO and CRRT. The CRRT could be done in series, with the machine being typically connected to the venous limb of the ECMO circuit before the pump. In the view of pandemic of COVID-19 and what can you do if there is a surge of COVID-19 and resources become limited? We can think from running out of CRRT machines. So we can convert from continuous to prolonged intermittent renal replacement therapy using one machine for 10 hours on 2 patients a day, or 3 patients for 6 hours each. And we consider running at higher flow, targeting 45 to 50 ml per kg per hour of effluent if there is plenty of dialysate stock. We can also consider use of acute peritoneal dialysis. We can use the conventional hemodialysis machines to do slow continuous dialysis by decreasing the blood flow to 200 and dialysate flow to 100 ml per minute using the smallest surface area filter you have, and run for 8 to 10 hours. Choosing between these modalities will depend on the availability of the machines and the resources, and also the experience of the nurse staff to do that modality. If we have running out of the replacement fluid and or dialysate, we can lower the dose of dialysis in using an effluent rate of 10 to 15 ml per kg per hour rather than 25 ml per hour, especially after the first few hours. Once the metabolic control has been achieved, we can mix also our own dialysate for CRRT. There are a number of recipes. Here is one from one study in Journal of American Society of Nephrology 2020 to use these receipts like 1 liter of 0.9 normal saline, whatever KCl you need, or using of 1 liter D5 with 150 milli equivalent sodium bicarb and other to be mixed with 5 liter dialysate bag and serve at body temperature. If we had running of the capacity for conventional hemodialysis, we can arrange for stable patients without a lot of metabolic abnormalities to consider switching to 2 days a week hemodialysis, also to consider switching to 3 hours dialysis. How can we conserve the manpower and protective personal equipment in the surge of the COVID-19 problem? We can wait for clinical indications regarding dialysis before starting renal replacement therapy, and we can consider using high-dose diuretics and potassium-binding resins to delay the dialysis if necessary. We can watch the volume status and not aggressively volume resuscitate every patient with AKI. For suspected COVID-19 patients who would require renal replacement therapy, we should use one by one nurse staff and personal protective PPE. So it is better to consider postponing the dialysis till you get results back of the COVID-19 test. We can try cohorting stable COVID-19 positive patients together in the last shift with higher nurse-patient ratio rather than do all of them in individual rooms with one-to-one nurse staff. What are the access considerations? We should consider an internal jugular catheter, as some patients who may develop ERDS may receive prone position ventilation. Also, if the patient is being prone for ventilation, we will consider future dialysis. Looking the catheters immediately after insertion of citrate or heparin, as these patients may be hypercoagulable. If there is a chronic dialysis patient who has AV fistula or AV graft, conventional thinking is that they may need a central line to avoid unnecessary procedures in the COVID-19 setting. But in one study, Rifai et al. In 2018, it describes how it's possible to do CRRT using an AV fistula and AV graft. Regarding acute peritoneal dialysis, in ICUs, patient getting prone position ventilation, the acute PD with its high risk of leaks and concerns about position and metabolic control, it is probably not the right strategy. Drug dosing in AKI, especially when they need renal replacement therapy. There are no proven or established medicines which have been clearly shown to be beneficial in COVID-19. However, it is possible that they will be used in patients with AKI, so it is useful to review the clearance of these drugs. Like the common medication chloroquine, we know it has a large volume of distribution and dialysis will not remove a significant amount. Other medicines, remdesivir, have not been officially licensed or approved for open use yet. In this slide, it is a journal pre-proof regarding COVID-19 therapeutic options for patients with kidney disease. We have drug treatment options for COVID-19 and with potential kidney damage and dosage adjustment in CKD patient. We have long list of medications in phase 2 and phase 4, phase 3. The most common one, lopinavir and ritonavir. It is in phase 4 and phase 3. The drug should be administered at normal dosage and regardless of the hemodialysis schedule. And the most common renal adverse event was reversible AKI. The drug treatment options for COVID-19 and what is a potential kidney damage and dosage adjustment in CKD patient. We have many medications under trial and still, like remdesivir in phase 3 now. There is no available data about dosage with GFR, and regarding the renal adverse events, it was not reported, and there is potential mitochondrial toxicity. Another medicine is lopinavir and ritonavir. In the phase 4 and phase 3, drug should be administered at normal dosage and regardless of the hemodialysis schedule. One of the common adverse renal event is reversible AKI. Regarding use of chloroquine, there is dose adjustment according to the standard recommendation, and the drug should be administered after session of hemodialysis days. One of the the renal adverse events are renal lipidosis, mimicking Fabry's disease, and false proteinuria. Another medicine, tocilizumab, interleukin-6 antagonist, it is in the phase 4, and the drug should be administered at normal dosage. One of the renal adverse events are autoimmune GN like membranous, IgA, lupus, ANCA, associated vasculitis, and granulomatous tubular interstitial nephritis. This slide showed the most common medications used now. The first one is remdesivir. The dose reported in COVID-19 trials was 200 mg by 1, then 100 daily. No dose adjustment with AKI, and potentially cleared if creatinine clearance equal dialysis effluent dose. Other recommendations, the creatinine clearance less than 30 was excluded in the most trials. The other medication is lopinavir, ritonavir, Calitra. The dose reported in COVID-19 trials was 400 mg and 100 mg twice daily. No dose adjustment with AKI, with no dose adjustment with renal replacement therapy. The chloroquine and hydroxychloroquine, the dose reported in use will be 500 to 1000 mg a day, or 10 mg per kg. Regarding hemodialysis, regarding hydroxychloroquine, 400 mg per day, then 200 mg 2 to 3 times a day. There is no dose adjustment with AKI and no dose adjustment with CRRT. Also, tocilizumab, the dose is 8 mg per kg ampule, no dose adjustment or in the AKI or CRRT. Colchicine also used 0.5 mg twice daily, and there is dose adjustment with AKI and no dose adjustment with CRRT. Tocilizumab, interleukin 6 receptor inhibitor, is licensed for cytokine release syndrome and has been approved in patients with COVID-19 pneumonia and elevated interleukin 6 in one study multi-center randomized controlled trial in China. As we know, we have an updated information all the time regarding the COVID-19 surge, and we will update you with any updated data regarding kidney involvement and COVID-19 disease. Thank you.